Good evening, everybody, and welcome to our third session in our 2025 Better Billing Series, Medicare Changes with Care Plans. Where to from here? My name's Helene. I'm the Workforce Development Officer at West Vic PHN, and I'll be facilitating this evening alongside my colleague Jade. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience and the ongoing place that First People hold in our communities. We pay our respects to those elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PH Learn YouTube channel, and the link to that is on there. And please see our upcoming events on the screen now, and you can register for these events via our website. So the link will be in the chat. Our main event for the year is our 2025 Primary Care Conference in Ballarat at the Good Shed. That's open at the moment, and registrations are coming in really quickly, filling up for that one. So go into our webpage and have a look at that. Very excited to have Samuel Johnson as our keynote speaker. So looking forward to him, and he's doing a session there also. Just a reminder about our Health Pathways, a free online resource with localised clinical and referral information for health practitioners, and that link is on there also. A certificate of attendance will be emailed to you all, so please take a moment just to check that your full name is displayed accurately on your screen. If not, just pop it in the chat box so that we can make sure we get the certificate for you. The event is being recorded, so please keep yourself on mute throughout the presentation and put your questions in the chat box. Because of the large amount of people in the audience this evening, the questions will be addressed at the conclusion of the presentation. Your feedback is important, so if you could take the time to complete the event survey, we'd appreciate that. And our presenter for this evening is again Dr. Ashley van Leeuwestyn from Better Billing. So welcome, Ashley. I will hand straight over to you.
Thank you. Thanks, Celine. Just give me 1 second. I'm just going to share my screen. Okay, just making sure we can see that. Helene, Jade, if you want to give me a heads up that we can.
Yep, all good.
Yep, awesome, perfect. So welcome everybody to our GP chronic condition management plan presentation tonight. So I've done this a few times now for a few different locations around Australia, and this is a really hot topic obviously at the moment with these July changes. So I am Ash from Better Billing. So I created Better Billing a few years ago as an online MBS education platform for GPs, practice managers and their nursing team. We also do a lot of webinars, which is where you're meeting me again tonight, and also provide one-on-one support with practices as well. So if you're interested, you want to look at my resources after this, there'll be a link at the end. It's all through my site and all free through our resource hub. So just go through here. Okay, so our learning objectives are on the slides. However, if you're wanting to have a look at that, you're very welcome to, but let's talk a little bit about what these new MBS items are. So when you hear me talk tonight, you're going to hear me say 965, 967, 92029 or 92030. And what I'm talking about here is 965 is the creation of the new plan. So I will still use the words care plan. It's not exactly what it is anymore, but it will come out of my mouth as I start to speak. So please know that when I'm talking about care plan at this point, I'm talking about the new one with 965. 721 is being replaced by 965. And you can see there that you've got 967, which is the review, which is replacing 732. And what you can see here is that the fees are all equal. Okay, so you've now seen for the first time that you've got equal fees between both the created initial care plan and those reviews. So we'll go into a little bit about why that's appeared as we go on. So let's talk about what's staying the same. So what's staying the same is that every 3 months you can still do your reviews. Okay, so plans can still be prepared every 12 months, so that 965 can be done every 12 months. However, the point of the reviews being equal in your fees is that it encourages regular reviews rather than the creation of a new plan. So back previously when we had 721, 723, and when we had our 732, 732 reviews, what was happening is that most GPs would end up maybe doing one review and just renewing a care plan every year. And that's not the purpose of the chronic disease management plan numbers in this case. What they're wanting is they're wanting reviews that are done every 3 months, or every 3 months, 3 to 4 months, however you're doing them, and encourages using a review rather than the creation of a brand new care plan. What is staying the same is you're still getting those 5 individual allied health visits per year that are applicable and allowable for allied health, and we'll have a look into the difference of what that looks like. And then we also have the 10 services for Aboriginal and Torres Strait Islander patients, as well as the 8 eligible group sessions for diabetics, particularly exercise physiology and dietitians. So if you have those guys in your area that offer group sessions, they still remain the same. Reports from allied health are still required for their first and last visit under the care plan assigned allied health numbers. However, we are not requiring a signed TCA anymore, or any sort of information for us to complete our reviews and bill the care plan. But again, we'll look into this a little bit more. So what changes are being made? So we're trying to get rid of the duplication of your GPMP TCA. So that is gone. The team care arrangement is completely gone. So what you're going to see now is you're going to see the EPC form, that grey form, or using where you put in how many in the box you want your physio to have, etc., will be gone. That's no longer needed. The aim is to simplify care planning, and I feel personally in the last month that things are much simpler. It is easier. And hopefully improving some access and coordination for patients getting access to allied health without having to have the extra providers, etc. And they're linking care plans with the continuity of care via MyMedicare. So we'll touch base about MyMedicare towards the end and why it's important in these new changes. But let's continue. So other changes that are being made, as I said, 721, 723, 732 are gone. If you've been trying to build those, they are not working as of the 1st of this month, July. They're being replaced by what they call the GP Chronic Condition Management Plan. Referral forms are replaced by letters. So just like you would traditionally be doing a letter to a non-GP specialist, they are having the same for allied health. So I have some templates at the end if you're interested in having a look at how I sort of do my templates in our referral forms, and what we can sort of see in terms of simplifying that, in easing that for your patients, and also in terms of the referral forms for allied health, they do not need to be named. So if your patient says, I really want to try this physio, but I want to see how I go with this one, I might find someone closer to home, you can use an unnamed referral. You also no longer have to specify a number of sessions. So 5 sessions is still the basic amount. However, if you do not specify it on that form, that is okay. However, if you do, you can still specify. So I might say, 2 for exercise physiology and 3 for physio. That is also fine. So as I mentioned before, equal fees for both plan and review. And then we've also got something called the 2-year transition period, which I'll chat about with you later. So other changes to just be wary of as well is in 2 years' time, home medication reviews will require the patient to have a GP CCMP to be able to access that service. Okay, so by that point, hopefully we're all still in the swing of it and be able to see how easy it is to access the new CCMPs, and having those patients who are likely going to benefit from a medication review are likely going to have these new care plans in place anyway. But that will be a requirement from the 1st of July 2027. Obviously, your COVID numbers have ended, if you haven't already noticed. So they're completely gone. And we've got the introduction of the menopause health assessment that started on the 1st of July as well, which has been good. Okay, so let's talk about MBS's requirements as per what they've got on MBS Online. What does it mean, etc. So, having a look at 965 on the left hand side, this is about the preparation of the plan. And this is what Medicare wants you to do in that session. So, the 965 and 967 numbers are pure GP item numbers. So, the GP needs to see the patient on the day. They need to be involved in this consult. If they are not, then it's not able to be claimed. So, what you've got here is 965 patients who can have one is still the same. So patients with a chronic condition or a terminal condition, so their condition has to last more than 6 months. Now, there has been also mentioned in the MBS Online specifically around what connotates a GP being able to say this is the conditions that I can give a care plan to and what doesn't. And they haven't really given us a particularly great answer, but have left it to the discretion of the general practitioner if they feel that this is a chronic condition that the patient is suffering with for more than 6 months, or they would benefit from the new care plans or the CCMPs, then they are within their right being able to do so. It is now simplified because obviously we don't have those arrangements for team care if that's the requirement, and that sort of simplifies those things there, and also is giving a little bit more power to the GP to be able to initiate that if they see it appropriate. So the written care plan itself needs to have shared goals with patient action. So if you've ever seen any of my previous care plan talks, it's always about SMART goals. They're my thing. Plan services that we've also got that the patient might be getting. So they might be seeing the diabetes educator, they might be seeing the podiatrist, and then offering your multidisciplinary referrals during that time, and then always mentioning about consent, the copy of being offered for the plan to the patient, and the plan being added to your records, so that BP, medical director, whatever that might be. Now they say you can bill a 965 every 12 months, so if that is what you wish, or earlier if exceptional circumstances apply. So there's been a new change in condition. Someone may now become palliative, etc. Those are those exceptional circumstances. Then having a look at 967, that's when we've got our review, and the review is where we're literally looking at what your previous existing plan is and looking at where their goals are and their progress and their goals. So say, for instance, you might say to your patient, Marge might be looking at trying to lose 10 kilos to help reduce her diabetes, HbA1c. We might say to her, how are you going, Marge? And she might say, oh, I haven't really lost anything yet, or I've been doing good. I've lost a few kilos here and there, but I really want help with X, Y, Z. And then you talk about the allied health input. So how has their allied health been actually going? Did they even see the dietitian? Did they see the podiatrist? Have you had any reports? Can you reflect on it with the patient during that review? And then the updated actions and referrals. So if there's more referrals that are needed, so all of a sudden they've decided, I want to choose to give my extra 4 sessions that I've got left, I actually want to go to exercise physiology now, I don't want to see the dietitian, whatever that might be. And you can do those reviews every 3 months or earlier if there's an exceptional circumstance, again, like I mentioned. So the patient now being able to access these plans, they either must be registered with MyMedicare through the practice, okay, or be able to see through their usual GP. Now, if for some reason the patient has seen their usual GP and their usual GP hasn't had the opportunity to add them into MyMedicare or register them for MyMedicare with us, and they may see another practice down the road, or they might share that practice with another GP in there, whatever that might be, and you end up completing the 965 or the new care plan. What ends up happening here is if your patient is registered to another practice, as an exception will appear for that care plan. So we'll talk about MyMedicare a little bit as well around looking at how to get increasing your patient's uptake of MyMedicare, because now it's starting to directly affect our billings around our care plans. So some of our patients are not interested in registering with MyMedicare, which is fine. However, if they are regulars there, you're seeing them often, I really encourage you to get them registered. Then another thing that's seen at the bottom there, you can see it says cannot co-claim with standard attendance items. So Medicare has now actually mentioned this explicitly. So there was a little bit of a trend that I was starting to see where there might have been GPs billing a 23 with a care plan at the same time because they've decided they're talking about, another item number that's different or whatever that might be. But in this particular case, they've really specified that, you know, co-billing with a general attendance item being a number 23 or 36, etc., is not actually recommended. So in this particular case, I would say be wary, be clear of it. There are exceptions to that rule. So obviously, if you have an acute issue with an emergency problem that cannot wait for the next day, then that is absolutely what you can do. You can bill a 23 that might be irrelevant, but if you're seeing them for reviewing some other issues that are non-urgent and you are audited, that is absolutely, it's not going to be compliant. The other thing is, as I mentioned, the GP must see the patient. The nurse may assist in the creation of the care plan, the new care plan, or the review of the care plan, but you cannot bill 10997. And this has been really clear and explicit since the change. So you can't actually bill the 10997 unless an activity is happening with the nurse's time during that. So activities that I'm talking about here might be, influenza vaccines, Prolia injections, using an ABI machine, having an ECG done, talking to them about diabetes control, giving them a Libre sensor, whatever it might be. But the creation of the care plan and now the review time of a care plan is not able to be claimable for 10997. Okay. So patient scenarios. So let's talk a little bit about what patient scenarios are coming through the door, where these are the most common questions I'm being asked. And that is where you've got, after the 1st of July, what does it look like? So we've got a patient who's had an existing previous 721, 723, and they're attending for their plan 732 review. So my best recommendation is you start all patients with a new care plan with the 965. So for the first 3 months, we should not be billing any 967s. So everyone should be just billing 965s. Even though it was a previous review, you want to start the patient on a 965, and then the 967 is the item number that comes after that. If the patient, however, is needing a new care plan or they fit the criteria, the GP decides they benefit from allied health for their chronic condition, then all of a sudden you can just start immediately with the 965. So let's have a look at what the referral process looked like before and now the referral process now. So previously here on the left-hand side, you've got where we used to have your GPMP and TCAs. You'd send off your TCA for co-consent. You'd bill the 721 and then you would hold off for your signatures to bill your 723. You needed to have 2 providers for the team care arrangement. So you had to have physio and a dietitian, or you needed to have, there might have been another non-GP specialist like a cardiologist and an exercise physiologist, whatever that might have been, but you needed your 2 providers for TCAs. Now here on the right, what you can see is you've got your new GP CCMP that's been created. You provide the allied health referral if you require it, and you bill the 965. There's no waiting on signatures, nothing like that. You just proceed right ahead. There are also no minimum providers, so you don't have to have any providers. It could just be you as the GP managing the condition if you require. Okay, so let's talk the transition period. So the transition period is between 2025 and 2027, and this is where the allied health sessions from old previous care plans, including 721, 723, are still remaining valid before the 30th of June 2027 under previous care plans. So if patients need a new referral or there's been a change and they require a new referral and a new year's appeared, then transition them to new care plan item numbers such as 965, 967. After the 1st of July, any allied health sessions that might have been created from old previous care plans are no longer valid. And so those patients will need to access a new GP CCMP if they're wanting to see their physio, dietitian, podiatrist, whatever it might be. So let's talk a bit about money and the financial difference of what these care plan changes look like. And so what you can see here is I've got my 9.9% number. And what I'm seeing in terms of 9.9% is that's the average billing of a chronic disease plan item number. So when I'm talking about care plans, so 9.9% of billings fit around care plans. Now, there's a few things to reflect on there is one, where is your own billing rate of chronic disease? If you're a practice manager, how are you going as an entire practice? If you're a GP sitting there thinking, okay, do I bill probably about 10% of my billings? Are they care plans? What do they look like? So have a look and reflect on your own billings. But in terms of where our average Australian one is 9.9%, The issue with this, though, is that about 60% of patients within the general practice population do benefit from and do fit the criteria for a chronic disease management plan. And so when we kind of reflect and think about that, there's a lot of missed opportunities here and a lot of missed management plans for these patients. So if we have a look at what the fees were like and the average billing for most GPs on the left-hand side, what would happen is a patient might get a care plan and they may do a review at one point during that time, and there might be a 10997 because the nurse has been able to, give them a Prevnar, or they've given them the Shingrix, or Prolia has been due at the same time. And so on the average fees that have been derived from that for a GP that's billing averagely on the left side, it's about $512 in terms of that patient. And then if you have a look at care plans after the 1st of July, we've got a substantial cost difference. So obviously previously, before, if we had a GPMP and a TCA, we were looking at $294.60, and now we're looking at $156.55. Doing one review each year with a nurse support item of 10997, all of a sudden our fees look a little bit different. So the average GP is doing about 2 care plans a day, and they might be working 4 days per week. So what that actually equates to, when you think about it, is about $1,100 loss in billings each week. And so I really encourage everyone to sort of reflect on, okay, what can I be doing better? And one of the biggest things that I always talk around at this time is around co-billing and what you can and can't co-bill. So having a look at your co-billing reminders, this table is in most of my presentations. You'll be able to see it at the end. If you want to take a photo, whatever you want to do, that's fine. However, when I look at co-billing reminders, this is in relation to 965, which is the new care plan. Okay, so general attendance items is a no. What you can do is mental health care plans, mental health care plan reviews, health assessments that are being done at the same time, so 705 and 707, a heart health assessment for a 699, the menopause health assessment, the 695. If the patient identifies as Aboriginal or Torres Strait Islander, a 715. If you've got other investigations like an ECG, if you've got an ABI machine, or if the nurse is doing other activities that are relevant to the goals, so that might be a 10997 or a 10987, is absolutely applicable during that time and can be co-billed. So obviously those general attendance item numbers with the 2713, which is the mental health care consult, and that is also treated like a general attendance item number, as is the antenatal attendance. The answer is no, but it's also no, but could be. So what I mean by that is that emergency, acute reason the patient needs to be seen today. I can't wait for a few days. I can't wait for a day after for that patient to be able to be seen at another time that isn't their care plan time. Okay, so think about how you're currently billing in terms of what are we missing? Are we missing the opportunity for mental health care plan reviews? Have we missed a lot of healthy hearts during the time? Can we be doing these during the time of our care plans? And it all looks up to yourselves as to what works best for your practice, but these are able to be billed, and a lot of us are missing this at many times. And with these decrease in fees, we need to sort of start to look at other alternatives to pop it back up. So let's talk about MyMedicare and MyMedicare's implications. So like I'd mentioned to you before, the patient must receive the plan or review their plan from their registered practice through MyMedicare, or non-registered patients can use their usual GP. And that is absolutely fine, as long as you don't find that your patients have gone down the road to another practice who have signed them up for MyMedicare because they've been there the 2 times in the 2 years, and all of a sudden now the care plan for the patient that Dr. Smith has seen for 25 years is now being declined because he's been registered with another practice. So I really encourage you definitely to look at options of how to increase your numbers. So as I've been saying in a lot of my talks, MyMedicare is everyone's business. So everyone in the practice needs to be sort of responsible for how we build up MyMedicare numbers. And so for admin, that might be looking at during check-in, helping patients register on the app if they've got their app handy, checking appointments in the next 24 hours and thinking, okay, these are the people, and marking it on the scheduler that I need to give these forms to. For our nursing staff and our workflow, what we start to see is at that first part of creating a care care plan is, does the patient actually have that tick in the corner? Are they registered for MyMedicare? If they're not, that form needs to happen at that same appointment. And also the same during health assessments. So while MyMedicare is not implicated in health assessments as of yet, we do worry in terms of the future about whether this is going to happen. However, it's important for your care planning. So definitely getting that done during that appointment is another great opportunity. And then for GPs, absolutely during their consult. So if my patient has seen admin and maybe nursing staff and still are not sure, and they've brought it to me and I can explain, this is what is happening with MyMedicare. They want you to be registered with me to be able to see me regularly, and for me to be able to access care plans and other telehealth item numbers, longer telehealth item numbers. That's why we're doing it. And if they're still not interested, then they're very much not interested. I personally also review my list for the day before I start and pop in where these patients might be needing to be registered for MyMedicare. So that I'll show you a little bit about how that works as well. So having a look here, this is my cycle of MyMedicare, and where it's everybody's business and where it might look like, opportunities for finding it. So like I'd mentioned, starting there in your reception, seeing the nurse doing their care plan, and then having a look here that, looking at all the opportunities of what the nursing staff might be doing. So they might be doing a 715, they might be doing a 707, they might be doing the other health assessments as well, and using that time to find, okay, is there MyMedicare occurring during that time too? And then seeing the GP during their appointment for the remainder of the item numbers that might be relevant. So they might be completing the appointment as they needed, reviewing the plans that's been done by the nursing staff, finishing off other health assessment items, numbers as well. And then what we'll do is future appointments and billing opportunities. So let's run through an actual patient of what this actually looks like. So I've got here in the right-hand side is Marnie, who I've created as a fake 44-year-old female lady, who is an Aboriginal patient and is hypertensive with type 2 diabetes. So this patient comes into the medical practice, and you can see here, okay, she's been registered with MyMedicare and they might have given her the form. And then what ends up happening is this patient today, I have got her seeing our nursing staff for her care plan and her referral to allied health. So in this case, it might be exercise physiology and diabetes educator, because we really want to drop that we don't want to drop that HbA1c with her exercise, and also keep her sugars going well with her diabetes educator. During that time of the nursing appointment, I've also got them involved doing an ABI. So if you don't have an ABI machine, have a think about it. It's a really good tool. It's definitely helped with a lot of our billings, but also really good for patients if you've got an older population cohort of looking for peripheral arterial disease. So in this particular case, I've got our nursing staff doing an ABI because the patient is type 2 diabetic and they're hypertensive, so they're an at-risk patient. Then they end up coming to see me during their appointment time. And so what I do is I might complete the healthy heart assessment during that time and run through with Marnie about her lipids and her diabetes control, and explain about where she sits in her cardiovascular risk percentage. So at that point, I'll also review the plan and say, okay, great, we're going with the diabetes educator this time and the exercise physiologist. That sounds great. She might need prescriptions, updated referrals, chat with me about something else. And so that happens in that appointment time with me as well. And then what you'll be able to see here is the billing of what I've been able to do. So 965, 699 and a 11610. So you'll be able to see those billings have been able to be done as a co-billing, because you are able to co-bill all of those item numbers rather than just having the care plan appointment time. Then having a look at future opportunities and what we can do in the future. So say, for instance, I've chatted with Marnie about having her flu shot, and she's going to bring the kids in next week. So I've booked her in for her influenza vaccination, and that's going to be relevant for, say, her 10997 code. So the nurse is initiating an action in this, and that is a vaccination, in getting that done. Her 967 is booked in 3 months, so she's going to either be seeing myself or the nurse during that time. And then I've got her 715 that's due in 6 months. So I'm also getting that pre-booked in ahead of time as well. And all of those particular item numbers, so your 967 and 715, these can be co-billed together. So if you can see here, you've got the 3-month one where you've got 967 that's been completed. 3 months later, you can be doing your 967, so your what will be your second review with your 715 if it's also due at that 6-month mark too. So those are other opportunities that you can use during with these care plans. Okay. So then I always like to put in about what my plans look like and a little bit of a about different ways to be able to send them off to allied health. I really quite like productivity and making things as easy and simple for GPs sitting in the chair. Being a GP myself, all I want to do is make sure my notes are good and go home on time, and that is admin is our biggest thing. So having a look here, you can actually see the BP screen at the top. So I use best practice. And yes, you can definitely use this template here, which is it's still being named the GP management plan, and you can go through that. However, if you are, not terrified of AI and you're interested in AI, this here is the screen for Lyrebird. I'm a big lover of Lyrebird, and what you can see here on the left-hand side is what I've done in our consult. So this is a fake patient that I've created named Mia, and we've talked about her endometriosis and her pelvic pain, and she wants to go to the pelvic floor physiotherapist. And in this case, I'm doing her care plan. So ignore these top bits here. These have changed if you're interested in getting this template. And from our consult here, I've actually been able to AI generates a care plan for me with these goals. And these goals are absolutely Mickey Mouse. So we're talking perfect SMART goals. So in her case, she's got reducing pain days and time off work by 50% in the next 12 months with assistance from her exercise physiologist and her physiotherapist. And so what you can see here is the real cut down of SMART, if even just to really hone in that if I was, ever going to have auditing happening within my care plans, they are very clear and very succinct goals, and they're directly related to what I've discussed with Mia in her consult. So if you are interested in having those templates, if you currently use Lyrebird or use other AI options, I have a whole host of free templates for you to be able to download and use on when you're ready to use them. What I tend to do with these is copy this and pop it into best practice at the moment. Lyrebird does have a care plan template that it has released. It's okay. I think mine's better, but it's something to at least think about if you're looking for time-saving opportunities. And with the care plans, the new care plans having a reduced rate, this is something I've implemented even more because it's quicker and I'm not relying excessively on nursing time, which I cannot be billing for 109.97 in creation or reviewing of my plans. So then this is another option here of how I sort of just fit in the care plan and send it all in as a allied health template. So this is my new referral here on the left-hand side. You'll be able to see this is our fake patient, and you can see a chronic condition management plan has been identified for this patient that requires allied health. The number of sessions allocated is here. I personally like to have allocated sessions. It's okay if you don't wish to have them. Find the referral details below with medical history and then copying and pasting the care plan. And this is one that's been taken directly from the BP panel preview. But if you are using AI like myself, I would attach my care plan that's been created through AI in that spot and then directly email it off. So I can pretty much create the care plan in most consults after that's getting completed in about 30 to 45 seconds, which is substantially quicker than what we were all kind of previously doing. So if you're looking at AI, if you're thinking you'd like to try an AI note system, I do not have any links with Lyrebird. I just use the product and love it. And so I recommend having a look at it too. So being in your practice, what do we do? So, and what should we do with these new care plan changes is I recommend sort of having a little bit of an audit of your practice list for active patients who've had recent 721, 723, 732s in the last 3 to 4 months. Have a look. When is their review? When is their review due? Do they have reviews booked? Should you be looking at increasing, contacting them, putting it through hot doc having a text message drive, whatever that might be. Update your templates and referral process. So add your templates into BP. So that might be your new allied health referral letter. Make sure they're added to your favorites for a quick access of it as well. If you haven't already, training your clinical and admin staff on the new item numbers and rules. So, show them this video, this recording, absolutely, that's completely fine. And then make time at your staff meeting just to really go over those changes, and really just communicate really clearly about what this looks like in that transition. If you are interested, I'll show you my template in the end as well. Better Billing, it's just a little bit of a plug there. If you're interested in having a look, we've got courses. We have note templates for those who like to still type. So we've got about 110 note templates for you to be able to use, which you can use. We do a little bit of coaching, but also mostly webinars now. And then we also do practice solutions. So if you're a practice who would really like to see us come out or come out for the week, etc., send an email, let me know, and we can have a chat if that's something you're interested in. So questions and discussions. So here on the right-hand side is, I think this has gotten around on the practice management page quite a bit on Facebook on the right-hand side, which is your GP chronic condition management plan information sheet, which I've created as an infographic. It's really good to just give to your admin staff, nursing staff to have at the desk so that they can be like, hang on, what's going on again? What's the new rules? And it's just a real summary of what I've said tonight. So about the item numbers, the fees, what happens with referring to allied health, why does MyMedicare matter, and just other points at the end of it there. If you have a look on that QR code, that will take you to my website. What you'll be able to see on the main page is a button called Resource Hub. Resource Hub is completely free. All you have to do is just log into the site with either like Facebook, Google, or whatever your email is, just to log straight in, and then you can download any of the templates that I've talked about tonight. And there's a lot more in there. I've got templates for health assessments, diabetes risk assessments, 699, 695. I quite like templates, so you're very welcome to have them, and they're all pretty much RTF formatted, so they're ready to be uploaded into BP if you're looking for them. They are also available in both AI through Lyrebird and also created for your system software. So I'm going to open the chat box, which is going off at the moment. And so I'm going to just quickly go through it. Okay. Okay. How easy is it for a patient to change their MyMedicare registration to a new practice? Really easy. So all you need to do is, as a practice, give them the other form, re-register them, or help them register that on their app. So registrations are mostly done through Proda, so you can register your patient to the practice. They have to fit the criteria, which you complete on Proda, but it is very easy to convert a patient who might have moved away or has moved practices to your new practice. Okay. Okay, so I've got a question here. I know we're an exception to the rule, but our GPs work across two practices 20 k's apart. Our patients travel between the two clinics, often depending on clinician availability. If we sign them up to MyMedicare, we can no longer get the benefits when seeing them at the other practice. It's been a nightmare. That does sound like an absolute nightmare. I'm going to think a little bit about that one. I'm going to get the guys to send me your email as well, Anna, but that is quite difficult. Let me have a think about it and see if there's any other ways that you can kind of get around that. But I don't have an answer for that right now, but I want to think about it. I feel like the 699 doesn't get done as it's 20 minutes time-based and usual appointment time is 15 minutes. Any suggestions to get these through co-billing? Yes, Gemma, I love 699 and I only ever bill it if I have a care plan done, because you're right, it's got to be 20 minutes and it's got to be bulk billed, and it's a bit of a waste of money versus time. And so in this case, I only ever co-bill it. So how I've been doing them at the moment, so 699s can be done with nursing time as well as your own. So our nursing staff have been able to do 15 minutes of the 699 appointment for me. And that might be completing, their form, looking into their history, asking about family history, bringing all of their bloods together for me. And then what happens is the 965 or the care plans, they're actually not time reliant. So you don't need to spend any amount of time on those care plans. So if I have a 15-minute appointment with me afterwards, the 5 minute of that time goes to the 699, and then the other remaining part is used as care plan time or any other time that might be relevant during that. So that is how I co-bill that during that time. And I rarely bill it alone because, as I said, not really worth the money. Got to do 20 minutes, has to be bulk billed. And so this is the way that I do it. Can I get a copy of that GP chronic condition management plan form? Absolutely. Go straight to the website right now and you'll be able to get onto that straight away for free. What is the AI name that was previously mentioned? So Lyrebird is the one that I use. Just Google it. It's created by insanely by like two 19-year-old Australian guys who have obviously done really well. And it's very, very effective at note-taking system. I have tried all of the AIs and it's probably my favorite, but it's very, very good at template creation, which is one of the things I do a lot of. If you use a new template and use MD, does the data get picked up for better reporting? We've tried using a new 715 template and our data was not being captured correctly. Okay. Bit of an interesting one there. I will have to get back with you on that one. But in terms of the data, it shouldn't be an issue because my templates pick up data directly from investigations and directly from patient demographics. So see how that goes. And the other thing is within MD and BP is making sure that the data is filled in the areas themselves. So rather than just saying non-smoker, but actually having it filled out as a smoker, it helps with picking up your data as well. Okay. One more. Can you allocate extra sessions to a psychology with the CCMPs when they've used all 10 mental health care visits? Yes, Gemma, you absolutely can. It's a less of a rebate for them, but it's still better than having to pay completely privately. But yes, you can, and I have done that a few times as well. Okay, I think that's all the questions that I have. Jade, you've popped in the evaluation survey thanking you. If there's no other questions, I might stop sharing my screen.
Hi everyone, it's Helene again. We do have some time, so if you've got any questions, pop them in the question box, or happy for you to take yourself off mute and ask a question.
I actually had a question of the MyMedicare that was, sorry, I don't have much of a voice.
That's okay.
We are a locum-based clinic, so with regular locums, and we have our patients register to one clinic. Some do go between our two clinics. So if you could also send me the information on how we could have it that
how that would work,
how that would work. I did do a little investigation on it, and it looks like you can have one as a main hub, but if you could let me know if there's any other way.
Yes, I will have a look at it. I believe I actually had to help somebody with this a few months ago that was looking at something in my consulting role, but I will have a look at it for you again. And yeah, Helene and Jade, if you don't mind giving me the two contacts for I think Andy and Gemma, that would be great, please.
Thank you.
So I've got another one, another question in here. Now that the plans are 18 months, can allied health practitioners bill 5 in one calendar year and potentially 5 in the following 6 months? Yes, Andrea, they can. Yes, look, I personally have started to put in that I'd like my plans to be for 12 months, just so that I can register with the patient, recheck in with the patient that that's still relevant and that's what they want. But yes, you're right, they can. Just to clarify for that co-billing reminder table, who those blue items could co-bill with a GP CCMP. Yes, that's completely right. What is the equivalent of 965 for nursing staff? We have podiatry visiting on current EPCs in the RACF. Okay, sorry, nursing home. Yeah, okay. So the nursing home, you're still doing your 731s, and they don't change, and you'll be able to just like complete a referral to them under having their 731s done. So it would just be like your classic normal traditional referral that you can do for that. No worries.
Okay. Nothing else? Thank you, Ashley. Once again,
No
excellent
worries.
presentation. Always look forward to your presentations.
Thank you.
And I'm sure we'll see you again
You will.
on the traps. Yeah, definitely. Thank you everyone for attending, and any other topics or anything you want Ashley to cover, please email me or put them in your survey, and we'll see you all at the next one. Bye everyone.
Thanks.